Good morning, everybody. I am Dr. Nand Kishore Kabra, Chairperson of IIP Neonatology Chapter. I welcome you all for this academic feast, learn from the legends, and I hand over these proceedings further to the moderator of today's session.
Hello, good morning everybody. I am Dr. Sridhar Santhanam. I'm from Christian Medical College, Vellore. I welcome you all to this talk on biochemical markers of neonatal sepsis by Professor Masahiro Hayakawa. As you all know, sepsis in the newborn is one of the commonest problems which we encounter in clinical practice, and surprisingly, it's possibly also the least understood of the morbidities. After so many decades of dealing with infections, we still do not have any clear definition of sepsis. The gold standard for sepsis is isolation of an organism, as you all know, from a previously sterile site, and that is mostly by blood culture. And this is one of the most imperfect gold standards, and it has very poor sensitivity. It's also limited by high turnaround time. It takes about 48 hours to get a result, and it's expensive. Hence, there's been a drive to identify other markers with high sensitivity and specificity in diagnosing sepsis. And this is of vital importance since it is very important to commence antibiotic therapy at the correct time. One of my colleagues once said, neonatologists know when to start antibiotics, but they have no idea when to stop it. And this is probably true, even from my clinical practice. So we need some marker which also tells us when sepsis can be reliably ruled out or is cured. Finally, it would be great if we could identify a biomarker which could prognosticate, that is survival versus mortality, or even if it could prognosticate to say that this baby is going to develop severe sepsis. There is a lot of interest, especially in a country like India or in other LMICs, in developing point-of-care diagnostic methods for sepsis also. And for the next 45 minutes, Dr. Hayakawa will dwell on the biochemical markers of sepsis. I'm sure that this will be a fruitful session given his vast experience in managing newborn. I will now hand over to Dr. Rita Bora to introduce our distinguished speaker. Dr. Rita.
Good morning to everyone, and good afternoon to Professor Masahiro Hayakawa. It is indeed my privilege to introduce Professor Hayakawa as a speaker for today's webinar on biomarkers of neonatal sepsis, a series of webinars hosted by the National Neonatology Forum of Kerala, along with the Neonatology chapter of Indian Academy of Pediatrics, and I thank the organizers for giving me this opportunity. Dr. Masahiro Hayakawa is the clinical professor of neonatology in the Center for Maternal and Neonatal Care, Nagaya University Graduate School of Medicine, Nagaya, Japan. Professor Hayakawa has a long list of international publications to his credit. His research interest includes therapy for perinatal brain injury, including stem cell therapy, management of congenital diaphragmatic hernia, chronic lung disease, fetal growth restriction, as well as quality improvement programs. He had been speaker in many international conferences, including conferences of Asian Society of Pediatric Research. He holds many important posts in different scientific societies of Japan. He is the counselor of Japan Pediatric Society, director of the Perinatal Neonatal Society of Japan, and also the vice president of Japan Society for Neonatal Health and Development. There are many more. However, to cut short the time, I would not mention those. I would request now Professor Hayakawa to begin his lecture.
Good morning, everybody. Thank you, Chairperson, for introducing me. So I'm very surprising too many doctors, over 250 doctors attending this webinar. So I'm just a little bit nervous. Thank you. So I'm Professor Hayakawa from Nagoya University Hospital. It's very honor to speak in this webinar today. And I'd like to appreciate the organized committee of this webinar and the staff of Harvard Medical Company for an opportunity for my presentation. Today, I'm going to lecture biomarkers of neonatal sepsis. Neonatal sepsis is one of the most important diseases in neonatal medicine, especially in premature infants. It causes the high mortality. Early diagnosis is essential to improve the outcome. So we need to good we need to use a good biomarker to diagnose accuracy. Before my lecture, let me introduce Nagoya and Nagoya University Hospital. For non-Japanese, famous cities in Japan are Tokyo and Kyoto. Do you know Nagoya? Maybe I think most of you don't know Nagoya because Nagoya is not so famous for non-Japanese. Nagoya is located on main island, located at the center of the main island of Japan, Honshu. Population is about 2 million and the fourth biggest city in Japan. The distance to reach south part of India and Nagoya is about 6,700 kilometers. Even though most of you don't know name of Nagoya, I think most of you know name of Toyota. Toyota is not the mobile company's name, but also city's name. Of course, the head office of Toyota is in the Toyota city. Toyota is about 30 kilometers away from Nagoya. This movie is our hospital, Nagoya University Hospital. Nagoya University Hospital is located at center at Nagoya. The total number of beds are about 1,000. We can provide advanced medical technology for patients with incurable disease and critical condition. This slide shows that Nagoya University Hospital. Our hospital is in front of public park. There are many cherry blossoms in the park. In early spring, the end of March or early of April, many people enjoy having picnic party under cherry blossom flowers. If you come to Japan in early spring, you can enjoy beautiful cherry blossom. Now, let me introduce perinatal and neonatal medicine in Nagoya University Hospital. We have 18 beds in NICU. As you know, critical baby are cared in NICU. And we have 18 growing care units beds. In growing care units, infant with mild condition or recovery from critical condition are cared. This slide shows the smallest baby I have experienced. Birth weight was only 318 grams. This baby has grown now. She is elementary school student and doesn't have a major disability. Yeah, this slide shows chronological change in neonatal mortality in Japan. Yeah, this is my photograph immediately after birth. I was born in 1963. About 6 years ago, 15 babies per 1,000 live births were died. Mortality rate was dramatically decreased in several decades. Now only 2 to 3 babies per 1,000 live births were died in Japan. This slide shows the mortality rate extremely low birth weight infant in Japan. As line chart indicates that mortality rate is decreased every birth rate. For example, in 1990, all infants born less than 400 grams were died. However, in 2005, about half of infants born less than 400 grams were survivors. Yeah, this slide shows today's outline. As you know, coronavirus infection was outbroken all over the world. Firstly, I speak about COVID-19 in neonates. After that, I present characteristics of neonatal infections, current status hospital infections in Japanese NICU, diagnosis of neonatal infection, and treatment of neonatal infections. Firstly, I'm going to present COVID-19 in neonates. As you know, COVID-19 is an infectious disease caused by severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. It was first identified in December 2019 in China, and it has resulted in an ongoing pandemic. At this time, more than 26 million cases have been reported across 188 countries and territories, resulting in more than 866,000 deaths. Yeah, in Japan, first wave of COVID-19 outbreak occurred in this spring from end of March to end of April. In May and June, the number of COVID-19, there are small number of COVID-19 patients. However, the end of June, the number of COVID-19 patients was decreased. The peak of patient number was end of July. Fortunately, now the number of patients gradually decreased. In Japan, there have been 69,000 confirmed cases of COVID-19 with 1,319 deaths from January to September. Several reports about COVID-19 in neonates have been published. Lasky reported characteristics of COVID-19 in perinatal medicine. Up to 3% of newborns may have detectable virus, but it's not clear when it was acquired. Most newborns do well. Based on 26 reported cases, affected neonates generally do well and need only supportive care. How about epidemiologic and clinical feature? The review published by Zimmerman said that SARS-CoV-2 could not be isolated from amniotic fluid, placenta tissue, vaginal swab, cord blood, and breast milk, while from neonatal nasopharyngeal and throat swab in 27 mother-infant pairs. One healthy neonate and 3 neonates who developed pneumonia test positive on throat, nasopharyngeal and anal swab on day 2 and day 4 of life. This slide shows neonatal outcome. In the article from China, among the 30 neonates born to 29 pregnant COVID-19 infected women, include 1 set of twins. 5 were diagnosed having COVID-19, 2 confirmed and 3 suspected. And the other 12 neonates present radiological feature of pneumonia, but none are diagnosed with pneumonia. 3 neonates developed necrotizing enterocolitis, although none of them were premature. This is a very interesting finding, I think. This slide shows the perinatal mortality and vertical transmission. Huntley reports that prenatal birth was about 30%, vertical transmission rate was 0%, newborn death rate was only 0.3%. This slide shows summary of COVID-19 in neonate. Vertical transmission was quite low. Most neonate infected COVID-19 were not critical, and the mortality rate was extremely low. It has been clear why symptom is mild in neonates. COVID-19 is novel infectious disease. Therefore, there might be many unknown issues in perinatal neonatal medicine. We neonatologists must investigate clinical characteristics such as risk factor and long-term outcome. After COVID-19, I lecture about neonatal infection. I present characteristics of neonatal infection. This slide shows the root of infection in neonatal medicine. As you know, there are three routes in neonatal infections. One is maternal to fetal infantile transmission, which is a unique route. It includes via placenta, via vascular, and via maternal milk. Others are healthcare-associated infections, such as catheter-related, ventilator-related, and so on. And last, infection from medical staff or families. Let me explain the characteristics of neonatal medicine. Newborns are physiologically immunocompromised, and neonatal infectious disease tend to get serious. Immediately after birth, basically, newborn is aseptic condition, so pathological bacteria tend to colonize newborns after birth, immediately after birth. As you know, maternal milk has some kinds of antibiotics and immune effects. Sometimes it is difficult to feed maternal milk in acute phase, and so antibiotics immune effect of maternal milk cannot be expected. And hand hygiene could be insufficient when patient condition is emergency. So as you know, NICU is unique for critical newborn on the same floor, and preterm infants are cared in incubator with warm and high humidity. They are a suitable condition for infectious disease. So there are some kinds of neonatal infectious disease. So include central nervous system infection, respiratory infection, bloodstream infection, intestinal infection, cutaneous infection, urinary tract infection, myelitis, ophthalmologic infection, and surgical site infection. Next, I present the status of hospital infection in Japanese NICU. Following report hospital infection in neonatal medicine, the article said, as shown in this slide, 11.2% of infants in neonates suffered from hospital infections. Incident hospital infections in very low birth weight infants is 3 times higher than in term infants. Catheter-related bloodstream infection is most common. Respiratory infection rate was 2.1 to 7.3 per 1,000 ventilator day. So we conduct a clinical study to evaluate Japanese status. Study protocol is shown on the slide. Infection data of 871 patients, 465 males and 406 females collected from 7 NICU in Japan. Organisms, focus, and risk factor were investigated. The mortality rate of neonatal infection was evaluated. This slide shows the incidence of neonatal infections. Overall incidence of neonatal infection was 6.7%. As you can see, smaller infants have more incidence, such as in male group, the incidence born less than 1,000 grams was 32.7%. Incidence in this group was 11.1, and the incidence born more than 1,500 grams was to 4.2%. And so, female group, this trend is same trend. there is the same trend. Incidence of male infant was 8.4, and that of female was 4.7. So incidence male infant was twice that of female infant. This slide shows the percentage of each pathogen bacteria. The result reveals that the most common pathogen was Staphylococcus species, especially percentage of medicine-resistant Staphylococcus aureus (MRSA) was high, and others were E. coli, GBS, enterocolitis, Klebsiella, and so on. This slide shows major infectious disease in very low birth weight infant. Sepsis was most common, and so 26.8% in male, 50.8% in female, overall 23.3%, and followed by pneumonia, central nervous system infection, staphylococcal scarlet skin syndrome, bacteremia, and so on. This slide shows the risk factor of MRSA infection. Odds ratio of male infant, sorry. This slide shows the risk factors. Odds ratio of male infant was 1.86. Of course, smaller birth weight is higher risk. Odds ratio of extremely low birth weight infant was 8.82. Ventilator risk ventilator was risk factor, but other devices were not associated with neonatal infection. This slide shows the risk factor of MRSA infection. Odds ratio of odds ratio of male infant was 1.28. Smaller weight is higher risk. Odds ratio of extremely low birth weight infant was surprisingly high, 42.88. And any device were not associated with neonatal infection. This slide shows mortality of hospital infection. Mortality rate infant with hospital infection was 10.3%, and that of MRSA was 20%. Odds ratio each group were 5.4 and 11.7 respectively. And Granotti et al. Report in 2018 pathogens or sepsis episode. In early onset sepsis, so GBS and E. coli were most common etiologic agent, according for 38% and 23 episodes. In hospital acquired late onset sepsis and coagulase negative staphylococci, the leading pathogen, was involved in 40% of all episodes, followed by Staphylococcus aureus, 60%, and E. coli, 60%. In community acquired late onset sepsis, E. coli and GBS were responsible for 41% and 41% of episodes. This slide shows the summary of status hospital infection in Japanese NICU. The number of hospital infection at the 7 NICU was 6.7%. The risk factor were males, very low birth weight infants, and ventilator care. MRSA infection were closely related with high mortality rate. One of the risk factors in MRSA infection was extremely low birth weight infants. Next, I explain diagnosed neonatal infection. This slide shows symptoms of neonatal infection. Most of infants with infection have non-specific symptoms at the onset, such as not doing well, poor feeding, and increasing gastric disease, and sometimes change in vital signs occurred, temperature change, hyperthermia or hypothermia, respiratory condition change to tachypnea or apnea, and heart rate change to tachycardia or bradycardia. And so neonatologists have to check laboratory tests when infectious disease was suspected. Laboratory tests are as follows: complete blood cell count, including white blood cell differential count, biochemistry, acute phase proteins such as CRP, urinalysis, cerebrospinal fluid test, bacterial culture, gram testing, and so on. Now, so I present a case with neonatal infection. A male neonate born at 26 weeks of gestational age, and his birth weight was 750 grams. The infant suffered from acute respiratory failure immediately after birth. Respiratory failure got better by ventilator therapy. On postnatal 10th days, respiratory condition became unstable. Urine volume decreased and overall health condition did not look good. We suspected infection and examination. This slide shows the result of laboratory tests. Which kind of tests are abnormal? And red letter indicate abnormal result, and leukopenia, and increased band neutrophil, and decreased platelet count, and abnormal liver function and renal function, and acidosis, and hypercapnia, and so on. This slide shows the utility of white blood cell count value. We must suspect neonatal infection when leukocytosis or leukopenia is found. And IT ratio of band among total leukocyte is one of the most important issues. When IT is more than 0.2, 90 to 100% sensitivity and 50 to 70% specificity to diagnose neonatal infection. And so this slide shows the white blood cell count value at the birth. The figures on this slide show white blood cell count and YT ratio change immediately after birth. As you can see, results should be, as you can see, white cell blood count and IT ratio changed dramatically. So results should be interrupted carefully. Acute phase reluctant were usually used to evaluate infection. CRP is one of the most common acute phase reluctant. CRP is acute phase reluctant, which includes with infection and inflammation with the response time of 6 to 8 hours. CRP is evaluated in 8 to 24 hours when sepsis is suspected, and 24 hours after first test. If CRP is within normal range, negative predictive value for sepsis is 99.7. This is very important things. And so we have to check chronological evaluation. Chronological evaluation is very useful. Bandic et al. Report the usefulness of CRP in predicting neonatal sepsis. Their results said as follows: the sensitivity, specificity, positive and negative predictive value of CRP were on 95.7%, 82.4%, 70.2%, and 97.8% respectively. The area under the curve AUC for the CRP ROC analysis was 0.948. CRP showed its usefulness in the diagnosis of neonatal sepsis. The other acute phase reluctant is procalcitonin. Procalcitonin is produced in parasite as a precursor of calcitonin. Procalcitonin increases with the response time of 2 hours after being infected. Its half-life in blood circulation is 24 to 30 hours. Sensitivity is a little better than CRP. And neutrophil to lymphocyte ratio is one of the biomarkers to detect the infection. The neutrophil and lymphocyte are key cellular components of the human host defense system against the infection. Increased number of neutrophil and decreased number of lymphocytes alert the clinician for an infection. Neutrophil to lymphocyte ratio, NNR, is simple biomarker of inflammation which can be measured in routine hematological examination. The neutrophil to lymphocyte ratio is also predicting marker in neonates. In this study, preterm infant with birth weight less than 1,500 grams and or born less than 32 gestation weeks are eligible. The results showed the area under the curve of neutrophil to lymphocyte ratio, NLR, was 0.78. Using cutoff point 1.77 for NNR, the sensitivity was 0.73, the specificity was 0.78, and the accuracy rate was 0.76. The prediction of an NNR, an easy and inexpensive and rapid method along with CRP in the neonatal period for diagnosis of sepsis will be more effective in detecting culture-proven sepsis. There are some reports that the neutrophil to lymphocyte ratio and the mean platelet volume value can be useful marker to predict sepsis in children. This study, the population is not newborn, but also children. And the median age of study population was 18 months. Neutrophil to lymphocyte ratio in the mean platelet volume value should alert clinician to possibility of sepsis and to initiate or change antibiotic treatment. And this slide shows diagnostic marker for neonatal infection. There are some biomarkers to diagnose neonatal infection. Diagnostic sensitivity of acute phase protein, such as CRP and procalcitonin, is not so high in early stage of sepsis. Negative predictive value of acute phase protein is high. Therefore, chronological evaluation of acute phase protein is useful for decision of antibiotic discontinuation. the utility of NNR has been reported in a few articles. There are few limitations for neonatologists to diagnose neonatal infections. Firstly, the symptoms of neonatal infection were unspecific. When patient's general condition allows some anxiety, neonatologists suggest infectious disease. Neonatologists want to get the result of diagnosed marker, CRP and CBC and CRP as soon as possible. So, and the chronological evaluation of test result is useful. But frequent examination cause iatrogenic anemia. And so smaller volume blood is better because iatrogenic anemia is avoided. Horiba Medical has produced useful device named microsemi LC667CRP. The characteristics of this device are rapid report and small sample volume. It spent only 240 seconds to measure CRP and CBC. As a result, became available soon. And sample volume is only 18 microliter of whole blood. And so no need to dilute sample from ear, lobe, or fingertip. It can collect the blood sample easily, even though from low birth weight infant. We have conducted a clinical study to evaluate the accuracy of small sample volume. Participants are 10 healthy adults, 5 males and 5 females. Average age, it was 28 years old, and the sampling method was a 2 milliliter vacuum volume sampling tube and 0.0 milliliter with microsample tube with using. Measurement performed using automatic blood cell count and CRP measurement instrument, microsemi LC667CRP. We evaluate the correlation between sample from vacuum blood sampling tube and from microsampling tube. Parameters are white blood cell count and RBC, hemoglobin, and platelet count. This slide shows the correlation between microsample versus vacuum blood sample. White blood cell count, RBC count, hemoglobin value, platelet count, all were well correlated. This slide shows the correlation between microsemi CRP and laboratory instrument. According to CBC, it was well correlated that data microsemi CRP and laboratory instrument. According to CRP, samples were whole blood cell and serum. It was well correlated that data between microsemi CRP and laboratory instrument. The report of microsemi CRP display white blood cell differential count, GNR, granular to lymphocyte ratio be evaluated by microsemi LC667CRP. This slide shows the summary. CBC, GNR, and CRP are biomarker to diagnose neonatal infection. Neonatologists can get the result of CBC, GNR, and rapidly by microsemi LC667CRP. The test result using microsemi LC667CRP were good correlation with the result obtained using the instrument in the central laboratory. Finally, I talked about treatment of neonatal infection. This slide shows the treatment of neonatal infectious disease. It is most important to support respiratory condition, circulatory condition, and others. Of course, administration of antibiotics is important. Other therapy were immunoglobulin, granulocyte colony stimulating factor, GCSF, and blood purification. This slide shows how choose antibiotics. In early onset infection, we select antibiotics empirically, refer to result of cell culture in vagina. In late onset infection, hospital infection, we select antibiotic refer to microbe colonization data of the baby as well as those of patient in the same ward. Yeah, do you use immunoglobulin? Even though no evidence of the effectiveness of immunoglobulin to infect infant, Cochrane Review 2010 wrote that the effectiveness might be proven depending on the result of INIS trial. One was a clinical trial. In 2011, the INIS collaborative group report in New England Journal of Medicine effectiveness immunoglobulin in reducing in death or severe after effect of 2-year-old patient was not proved. How about granulocyte colony stimulating factor? Cochrane Review 2010 said no improvement in survival rate was found when GCS was administered to patients with serious infection, but the subgroup analysis shows the improved survival. However, no negative side effect is reported in GCS administration can be considered to serious infection case with neutropenia. Extent transfusion has been performed as a neonatal medical care. The clinical trial conducted in 1990s showed the exchange transfusion decreased mortality rate. Now we can use endotoxin absorption column for very robust wet infant with sepsis. This slide shows that my experience of endotoxin absorption therapy. Patient was infant born at 20 weeks of gestation and birth weight was 560 grams. This patient suffered from severe necrotizing enterocolitis. So we conduct endotoxin absorption therapy. So this column can be absorbed endotoxin and other factors. So such as macrophage and so on. We conduct this therapy successfully. Yeah. Conclusion on this slide, neonatal infection is one of the most important diseases in neonatal medicine. Keep in mind that the early diagnosis of infection is very difficult, but CBC, neutrophil to lymphocyte ratio, and the CRP testing help neonatologist decision. The machine that can evaluate infectious disease with microsampling is very useful. Yeah, this is last slide. This slide shows Mount Fuji, the top of the Japan. Thank you for your attention. Thank you. Yeah.
Thank you very much, Dr. Hayakawa, for a wonderful presentation on neonatal sepsis, including diagnosis and treatment, and also dwelling on the basics of neonatal infection. First off, I'd like to tell all the participants, Dr. Hayakawa, actually, we are running short of time, and he has indicated that he'll take about 5 questions. So I may not be able to get all your questions through to Professor Hayakawa, but we'll try to sort of uh, include as many as possible. Dr. Hayakawa, one of the questions was you had mentioned many markers for sepsis. So what is the criteria that you would use in your unit for diagnosing sepsis, especially if your blood culture was negative? And the other, as a follow-up of that is, do you all routinely use placental histopathology, maternal placenta, the placental histopathology in diagnosing early onset sepsis or in treating early onset sepsis?
Thank you for your question. So you mean placental histology is useful for diagnosis, right?
Yes.
Yeah.
Do you use placental histopathology?
So usually, so we don't use placental histology, but sometimes so congenital and intrauterine infection sometimes help to diagnose placental histology. However, now bacterial pathogen cultured from vaginal swab or from neonatal blood and so on is very useful. So we always use the sampling from vaginal or neonatal neonatology is used. So not placenta.
Sorry.
Thank you.
The first part of the question was what will be the criteria in your unit for diagnosing as probable sepsis or clinical sepsis in a baby whose blood culture is negative? What tests would you consider as significant to diagnose sepsis
So
in your unit?
sorry, one more.
In your unit, in your hospital or in your NICU, which tests of all these tests that you said are you routinely using to diagnose neonatal sepsis if your blood culture is negative?
Thank you, Professor. Professor.
Sorry, Dr. Hayakawa.
Thank you for your question. So, so we use firstly correct blood sample and cultured blood and all as well as other side so such as so tracheal aspiration and skin and urinals and so on. So and so clinical symptom is most important, I think. If the baby was critical condition, so we should start treatment before result get. And so CRP is sometime response time lag. So CRP is not response immediately after onset. So I think so CRP is not useful on early phase. So we should start therapy on the baby's condition. And after that, so we can get many result and decision to continue or discontinue antibiotics.
Do you use the micro semi CRP in your lab, in your unit?
Oh, yeah, every time.
Oh,
every time. So
every
time. So we use because microsem device is very useful because so we can get result from very small volume sample and so easily measurement and so we can get result as soon as possible after measurement. Thank
One
you.
of the very interesting parts of your talk was the endotoxin absorption therapy. Dr. PMC Nair, one of our senior neonatologists, wanted you to just expand a little bit more on endotoxin absorption therapy.
Yeah. Oh, yeah, right. Oh, very expensive. But so I have three of us case conducted PMA endotoxin absorption therapy, and so very useful, very effective. But sometimes invasive to premature infant, or because of we can blood of baby outside and circulate, and so sometimes easily to bleeding, and some baby suffered from intraventricular hemorrhage and so on. However, in success case, so immediately start this therapy, baby's condition dramatically improves, and baby can survive. Thank you.
Thank you. I will hand over to Dr. Rita. Dr. Rita, you can.
Thank you, Professor, for your excellent presentation. I have one question with me. You had shown that some of the babies who had COVID-19 positivity had features suggestive of necrotizing enterocolitis. So were these babies having clinical features which were exactly similar to the other babies who have NEC in our day-to-day practice, or they had some differences, and whether the X-ray findings and the clinical outcome had been similar? So this is one question. And another one is your opinion regarding procalcitonin in the diagnosis of neonatal sepsis.
So your question is useful of procalcitonin?
Yeah, one is regarding use of procalcitonin as a biomarker, and the second one is regarding the babies who had necrotizing.
Yeah, so it is very difficult to answer. So we can check the CRP or procalcitonin in our hospital and get result soon. However, as a biomarker is not used. So in my opinion, most sensitive marker is IT ratio, immature of total neutrophil, IT ratio of white blood cell count. So especially in premature infant, IT ratio is very useful. So as I previously said, so CRP and procalcitonin has response time is just a little bit long. Several hours. So if the baby's condition is now getting worse, CRP or procalcitonin is not response, but IT ratio is usually response. Now, so we checked white blood cell count, and also checked IT ratio, and so we start antibiotic therapy. Right? Thank you.
Yeah. And regarding the babies who have necrotizing enterocolitis-like picture in with COVID positivity, so are the signs and symptoms almost similar to other babies who have necrotizing enterocolitis, or there are some subtle differences?
Just a moment.
COVID-19 versus no COVID-19 babies.
Thank you. Yeah. So fortunately, in Japan, the number of COVID-19 neonates is very small. So I have no experience on the necrotizing due to COVID-19. I'm sorry. Thank you.
Over to Dr. Sridhar.
Dr. Hayakawa, one of the questions was you had mentioned in late onset sepsis that you use surface colonization data. There was some interest in knowing, do you have a unit protocol? When do you do surface colonization of newborn? And how often do you do it?
Sorry.
Surface colonization in late onset sepsis.
Late onset sepsis.
Surface
Yeah.
colonization.
Just a moment. Yeah, your question is just a bit difficult. So late onset sepsis pathogen and the cause is just a little bit confusing. So I think so neonat get the pathogen from socially, so from family or community, and so and so. For example, in Japan, so Staphylococcus aureus is the most common in socially. So sometimes it includes MRSA, methicillin-resistant Staphylococcus. So and we thought every time. So when the babies with late onset sepsis come to my hospital, so we chose the community pathogen, and so we start the antibiotics for effective this pathogen. Thank you.
Thank you, Dr. Hayakawa. I again apologize to all the attendees because I think we are running out of time, and we have promised Dr. Hayakawa that we'll end by 12 noon. So I think I'll now hand over to Dr. Manjusha for the vote of thanks. Thank you very much, Dr. Hayakawa. That was very nice.
Thank you.
Thank you, sir. It's a great honor and privilege to have Professor Dr. Masahiro Hayakawa from the Nagoya University Hospital, Japan, this morning on this platform for his very crisp and deliberative state-of-art talk. Thank you, sir, for being with us despite your busy schedule. I thank profusely our moderators for the day, Professor Dr. Sridhar Santhanam, CMC Vellore, and Professor Dr. Rita Bora, Assam Medical College, for joining us and conducting this session so smoothly. A big thanks to all our participants who joined us this Sunday morning. You are our strength behind all the webinars, and thank you for making all our sessions such a grand success. Last but not the least, I would like to thank our team, IAP NeoCon 2020-2021, spearheaded by none other than Dr. Manoj sir, for all the sincere hard work they are putting into each session that we are hosting on this platform. So till next time, it's bye from our team, and we'll see you next on 12th September, 7:30 p.m. for the talk on intermittent saturations. These saturations, what is the impact, by the renowned speaker, Professor Dr. Smita Sardesi from University of Southern California, USA. Thank you once again. Over to Manoj sir.
Thank you, friends. Hope to see you this week itself, this Saturday, for a common topic that we all encounter every day. Intermittent desaturations, what is the impact? So until then, goodbye.